First, let me take a minute to say thank you to the sponsors. Where are the sponsors? Oh, forget it. Thank you, Katie, for wellness. We have Orthomolecular, and we have Genova here. And the guy will thank them in the end. One of the things we really like to do before I introduce Jim is we want to create a sense of community. There's not that many of us around that practice this type of medicine, so it's really an opportunity for us to eat some food, chat and relax, and be in an informal setting. So just as a kind of so people know, there they are. So this is Brandon from Orthomolecular, Eddie, and Alexis from Genova. Thank you so much for helping us. She got the fine one. So I just wanted to actually see who's in the room. So how many, let's say, family docs are there? Internal medicine? Psychiatry? Who have I missed for physician-wise? Oh, GYN, a GI. Other specialists, the SIGLs, derm. Let's see. All right, cool. APCs, NPs, or PAs here? There you are. What's your? Cool. Welcome. And then RDs, we have 2. So, welcome. So we really have a great range of people that support our patients and our community. So, again, welcome. So let me introduce you to Jim. I've known Jim for about 6 years. I saw him lecture then, and he's only gotten better ever since. And it's really a privilege to have him here. He's gone around the country. He's saying in the past 4 months, he's had 15 different lectures around the country, so it truly is a privilege to have him here. Jim has authored many books, and I never remember, Walden, is it that you're medical director at Walden Behavioral? So welcome, and thank you for being here. Thank you.
Okay, can you hear me? So I have been giving a lot of talks, and when I was asked to do this, I said, as long as I don't have to do another PowerPoint, but give me a little board and some markers and I'm happy, because I tend to draw a lot of pictures. I'm really excited to be here because I think I shared with someone during the reception that really my goal and the rest of my career is just working with physician and professional colleagues about how we can address what I think is a huge tragedy in how we understand and treat mental illness. And I know as family practitioners and many of the specialties here, you are treating mental illness. And I can talk about many different mental illnesses. I'll share a little bit about what I do, and perhaps start a little bit on depression and mood disorders. And I really would like to make this interactive and collegial and really try to answer your questions. So we have about an hour, so let me start by telling you a little bit about what I do. I'm Chief Medical Officer for a hospital system. So we have an inpatient psychiatric unit where we see chronically mentally ill, as well as acute depression and suicidality, and an eating disorder continuum. So we have an inpatient hospital, residential, outpatient, partial programs throughout the state. There's 5 clinics in Mass and many in Connecticut. And as what I used integrative functional medicine physician since, the late 80s, the world of eating disorders kind of took me out of the closet. When I opened the practice, it was in Norwood, actually, so Route 1 was very familiar, driving this way in 1993. There were people in California in particular that lost their license. I don't know who was around at the time, for doing what I was doing in my little office in Norwood, Massachusetts, doing food allergy testing or prescribing a supplement. We had an ADHD clinic in 1993. And that year I gave a talk on integrative treatment for ADHD. Actually, it's right next door at the Holiday Inn. There were 250 people. But I was careful because I kept opening up our journals and people were losing their license for doing the kind of work they were doing. So it's really nice to kind of watch Ed's journey and seeing a place like this open up, because nobody is going to lose their license now. People are asking the information, right? They want to know what we do, and the academic centers are calling us for help. So it's wonderful to have seen that progress. But I still define my world as integrative. I like functional, but integrative makes more sense because I have not, as a psychiatrist, given up my prescription pad. It sits right there, and I've helped many people by prescribing a medication. But just as many people, hopefully more people, by looking at the underlying causes of what might be contributing to what you and I would call mental illness or symptoms of mental illness. So, as a physician, I've, for many years, close to 20 years, I've grounded almost everything I do with a patient with that medical model, which means I do testing, just like many of you here and some of our sponsors. Because of that fear early on from my colleagues, I base everything I do on testing. So I have many concerns, and there are days I get mad at the traditional psychiatrist for the polypharmacy, and then there are days I get mad at the functional physician for just putting a bunch of vitamins without kind of knowing what's going on. And so my world has kind of shifted to looking at a couple things. Let me just share those things. And I think I'll start with mood disorders and depression, and then if people are interested, we can talk about eating disorders for as long as you want. When we talk about depression and mood disorders, the most important thing that I have found over the years is just asking one question and spending a lot of time on the answer, and that's family history. Okay? Even good psychiatrists ask the question, anybody in your family with depression, substance abuse, or mental illness? And someone would say yes or no. Most would say no unless there's something dramatic. But for every patient that I see now, I have a social worker spend an hour before I see them getting the history, and I stress that this is not a 5-minute question. This takes 15 plus minutes, because not only do we ask the question, we go through aunts, uncles, relatives, and find out what is going on. Because again, the stigma of mental illness is rampant and profound, and what's discussed. But as our patients begin to tell us, well, Aunt Susie never came out of the house, or Uncle Bill was drinking every night. And then as you spend this time, 15 plus minutes, you get stories. And those stories are really critical. And you might not get the name OCD or depression or schizophrenia or bipolar, but you're piecing symptoms, and they're incredibly helpful. So, simple question, because, I think, the cancer world has kind of now marketed personalized medicine, and we can look at your genes to help which drugs might be helpful. Psychiatry might be critical to some, but there are now, I think this is the most fascinating Well, no, I'll say that probably about 10 times tonight. So this is one of the many fascinating parts of psychiatry we have to address. But there's a book by Rady. Anybody know Rady, John Rady? That, I don't know when it was written, but it's called Shadow Syndromes. So he describes that many individuals might not meet criteria for diagnosis of OCD or major depression or other major psychiatric illness or ADHD. So if you go through your little checklist, they might not meet criteria, but they have some of the symptoms. And that's where that family history and that genetic liability is so important. Okay, you might not get the name OCD from Aunt Susie, but guess what? You know, Susie had everything lined up perfectly. Wherever you went, she washed and followed you around the house. And that's really helpful when I see that 11-year-old girl presenting with food restricting. Okay? So the family history and the genetics. And I look at genetic testing. I have not found the genetics very helpful in terms of how we metabolize drugs, but I have found some of the kind of pharmacodynamic tests helpful in terms of anything from the COMP gene and MTHFR and other variables that help put together what that family history is with that genetic liability. So I would say the biggest change for me in my practice over the past 20 years is having this in my head before I treat a patient. And the other piece that is pretty clear to everyone here, but we have genetics, and then what's our next favorite word? What, epigenetics, right? So we all know what that is, all these things that can affect our genes. And it can be anything in our environment or certainly our diets and the stress in our lives. So we kind of have this package, and we can take depression, but then we can do eating disorders or any other illness. So what do we have? A, B, C, D, E. We have 5, what should we pick? 35-year-old women walking into your office with symptoms of depression. As much as we can get angry and irritated with the psychiatrist who thinks every depression is a Prozac deficiency, part of my anger now is with our community that thinks every depression is a 5-HTP deficiency. And it just doesn't work that way. And so we have 5 here, we'll go through, and some of the 5 reasons, there probably could be 20 reasons why our 35-year-old individual is depressed. And our job is to get the family history, look at the genetics, what's going on in their life, and then figure out how we can best treat the individual. So let's keep everyone awake. What might be some of the reasons a 35-year-old might be depressed?
Well, B12.
Okay, B12.
Could get more serotonin levels, genetic.
Could be. Let's say hormones, could be thyroid, any. Thyroid's a big one.
Toxic life.
What?
Toxic life.
Toxic life. We can make a list of mercury, lead, the whole thing. How about, what?
I meant those people in real life.
Oh. Well, we can do stress and people. Anyone read the New York Times has a case of the month, which is kind of nice because it's becoming very integrative. There was a B12 case a year ago, a gentleman who was quite debilitated until someone checked B12. I think he was non-ambulatory. And then the last one, last month, someone sent me, it was low copper. low copper in a male who was depressed. So most of us think of toxicity and high copper causing irritability, but low copper. Well, let's keep going. What else? Infections. Food allergies, food sensitivities. Vitamin D. So I met this woman today, this morning, who presented, a 35-year-old, chronically depressed, suicidal when I saw her a month ago. She had a vitamin D level of 7 and a few other abnormal tests. So I saw her as a follow-up, and she was too anxious to take the vitamins. That was like 3 months ago, and I said, you need to just take one. And eventually she was able, and the only thing she had been taking is vitamin D, and I saw her today. Appearance was very different, her mood was very different, and it was just the vitamin D. So clearly vitamin D. What else? Zinc, thank you. It's my favorite. We'll talk about that. Well, let's talk about it now, because zinc, like vitamin D, well, the nice thing about vitamin D, let me digress for a minute, it's kind of slipped into all of medicine, right? You don't have to be an integrative functional medicine doctor to get a vitamin D level. Not that they recommend the right dosages, but they're starting to, right? But at least they get that level and people are looking at it. There are not many things, I think, that have been that quickly kind of absorbed into traditional medicine. But the research on zinc and depression is becoming so extensive that hopefully that'll be slipping in as well. So there's a recent meta-analysis looking at many, many old studies, and it's quite simple that the lower levels of zinc, the increased rates of depression.
Do you think the zinc taste test is meaningful?
Do I think the zinc taste test is meaningful? I would say absolutely yes. I've used it for years. I don't use it much anymore just because of time, but we used it on our inpatient eating disorder unit just because it was fun, and it helped people feel like they might need supplements. And the only time that it backfired is in an emaciated, very, very malnourished individual that was clearly deficient in everything. I mean, life-threatening emaciation. They had a very strong taste. And I think probably because they were just breaking down tissue and muscle and cells. But so I've had one or two that didn't make sense, but over the years it's been very helpful and very accurate. So I like the zinc taste test. So we could go on and on, right? I'm sure we could all think of a few others. And I think that, my world of treating mental illness now is to begin to understand some of the physiological abnormalities. There could be one, there's usually more than one. So my other problem with our colleagues, and we all slip into it, is thinking, for whatever reason, we found the one answer without looking at the rest. And in the old days, when I started in Norwood, 1993, the test, you guys, where's Genova? It was cost patients almost $2,000. Okay? So there was not everyone that could do that. So I started picking and choosing which test to do. And I got burned sometimes because sometimes I didn't do my battery, and a year later when I did it, I found low copper. Because I did the trace mineral hair analysis, and I didn't do it at the beginning because I was trying to save the $10 here or the $100 here. So, kind of take home point number one, if we rethink mental illness, and that being schizophrenia or depression, as errors in physiology, whether it's genetic, epigenetic, or environmental, it doesn't really matter. The patient in front of you is depressed, is suicidal, is not sleeping, and not functioning. And can we find those errors in physiology? And I think we can, most of the time. Remind me about psychosis, but most of the time we can find those errors in physiology, and we can treat it. And then we can use words which doesn't happen in my world of psychiatry, like remission and cure. Right? When we talk about drugs for psychiatry, we talk about 50% improvement in depression scales. Now, what other field of medicine tolerates 50% improvement? Do you 50% improvement in acne, just one side of the face?
Well, 50% decrease in new lesions is considered a significant improvement. Psoriasis has the PASI score, and you want at least 50% improvement. 75 is better, but we take percentages in chronic disease.
Okay, so where I stand now is I don't want to tolerate a 50% improvement in my patients. It's too hard for me to sit in front of them or with their families for them to have residual symptoms. And we know 2/3 of our patients on antidepressants have residual symptoms. And to me, this is a model where we can use words like remission and cure, because we see it all the time, not with everybody, but with many. And I was giving a talk, I can mention names here, Standard Process, right, for a supplement company a number of years ago. And their lawyers looked at my slides before I could do the talk, and they wouldn't let me use the slide that said something like remission or cure associated with depression. And I kind of argued for a little bit. I said, but if they had a B12 deficiency and they were depressed and we treated the B12 and they're not depressed anymore, isn't that a cure? And these were lawyers, so they really wouldn't argue, but I had to take out that slide. And I think there's clearly a model where we can talk about remission and cure. I've seen it for all major mental illnesses, from autism to schizophrenia, depression to eating disorders. And I've seen failures in all disorders. I will just share with you the failure rate is lowest in depression with this integrative approach and highest in schizophrenia. And as I said, have not thrown away the prescription pad, because one of the most common things that I'm seeing, since my practice tends to be those that have not had success with medications and traditional treatment. And why haven't they had success? Because they've had side effects, right? Someone put them on Prozac and they had major side effects. And one of the nice things about our integrative functional medicine approach, as we clean up some of these physiological abnormalities, we can reintroduce some of these medications without side effects. And I've seen it all the time. So if your family, I'm going to go back, keep going back to this, and I see these patients, and if you ask the questions, I'm sure you will as well. If you have a family history where you have 2 uncles that committed suicide, you have grandparents that were depressed, one had ECT, and your 2 brothers are substance abusers, and your mother hasn't been out of the house, the genetics are not really that good, okay? And it's wrong, even if they have a B12 deficiency now, to think that B12 is probably going to help them completely from their genetic liability. But if we look at our integrative functional medicine model, I can assure you the side effects to those medications will be less, if not eliminated, and the ability to treat the illness will be 1,000 times better. So, can't get away from some of these really tragic genetic family histories, but we can work around it using this integrative approach. We have a gluten-free meal. No one brought up celiac disease, common cause of depression, mainly due when you start looking at the testing, the malnutrition, the zinc, the amino acids, and the B12. The fascinating part is you just don't know. And I kind of describe my work as detective work. I just don't know often. Sometimes with a good history you can figure it out. They've been on 10 courses of antibiotics. We're going to need to work on the gut. But my practice has been focused on what does it look like. Yes, sorry.
When you think about what the common denominators are here, you're talking about B12, zinc, hormones, blah, blah, blah. You have to go to the gut. And that's like the only place you can go is the common denominator.
Well, that's where
She needed the methylated tetrahydrofolic acid, but she had one mutation. Her brother had two. The brother was more interesting because he could never stay sober. He's in and out of halfway house, a lot of family support. Doctor put him, his physician put him on whopping doses of tetrahydrofolic acid, and for the first time he was able to stay sober.
Yep. The part of this family history we talked about is substance abuse, and part of, this complicated piece is that. I saw a gentleman today, I don't usually see that many private patients, but I did today, who has such a profound addiction problem to everything, from caffeine to nicotine to Adderall to porn. And that has never been addressed. He's been seeing psychiatrists, giving antidepressants, and no one addressed the addiction. And I think it's really like chronic mental illness, addiction, I think, is powerfully amenable to our integrative approach, and just not utilized enough. So with that, I thought I'd kind of just talk about two concepts that keep coming up in my practice and in my life, and then kind of open it for questions. So one, I guess I have to talk about zinc, because and then I'm going to talk about lithium. Where should we start? Let's do the zinc. The first book I wrote on anorexia, it was really mind-boggling. My career did not start out as eating disorders, but someone who's interested in nutrition and mental health. It was kind of a easy place to be legitimate because everyone was malnourished, and I could talk about nutrients, and people said, oh. And it was pretty scary that a disorder of profound malnutrition, and some of these women 10, 20, 30 years, and we're seeing a lot of men now, that there was never a study on nutrition, never a study on fat. These women are phobic about eating fat, and there was a couple of European studies on essential fatty acids and anorexia, but nothing in the United States on looking at nutrition. And in the work that I do, and in the years I'm even more passionate and adamant that I believe zinc deficiency is the trigger for anorexia nervosa in, what do you call them, preteen, what is the word, tweens, in that 11 to 12, 11, 13-year-old kids before they develop anorexia. Which means, the other word we don't use in psychiatry much is prevention, right? We just treat the crisis. So anorexia nervosa is the most life-threatening illness we have in psychiatry. Highest mortality rate of any psychiatric illness. How many people knew that? I did not know that 10 years ago before I started. Okay? It's got the highest risk for suicide of any psychiatric illness. I practiced inpatient adolescent psychiatry for the first 12 years of my career. I thought it was the hardest job. Very, very sick kids, and I was exposed to one suicide. I can tell you over the past 10 years, 20 or 30 patients that have come through Walden have committed suicide. It is dramatic, okay? It's a life-threatening illness, highest risk for suicide, highest stress on families, and anybody in the insurance business here, highest cost to our insurance companies, okay? So the model that is quite clear to me now is, one, genetics. And what are the genetics? It's typically OCD. And it might be not pathological, the symptoms might be quite competent. These might be the successful businessmen or accountants or women who are very successful. So the OCD is not necessarily a diagnosed problem, but it is that genetic liability to start obsessing about weight, food, body image. And obviously our kids are bombarded with this. But the disorder is only 3% of our kids, and 100% of our kids are bombarded with the same messages. So for so many years, we kept blaming the models and the magazines, but it really had nothing to do with it. It was the genetics, and what I'll share with you is the malnutrition. The vast majority of kids, okay, with this genetic predisposition, I should talk a little bit about the OCD, and these are perfectionist, kids that have not risk takers, kids that erase their lines if it's out of the box, kids that are involved in sports and getting all A's and folding their laundry, the kids that we would all want to have until they start obsessing about not eating. And the biggest variable, and I don't want anyone to throw anything at me here, but the biggest risk factor is a vegetarian diet. Okay? We'll get there. Okay, the biggest risk factor from this genetic liability with OCD is a vegetarian diet. So I've been doing parent groups for years, okay, on this unit, and I never bring it up, and then one parent says, Susie started being a vegetarian, and then the next parent, the next parent, the next parent. And the research shows it's usually 12 to 18 months after this vegetarian diet. And the studies that have been done, most of these kids are not raised in vegetarian families. So the parents aren't vegetarians, which means an adolescent vegetarian who's not in a home eating a vegetarian diet, what are they eating? Pasta, and maybe a potato chip, and maybe a Coke. So we're talking about, and we have research that vegetarian adolescents who are not in a vegetarian home are very unhealthy eaters. And this, over 12 to 18 months, creates a number of nutritional deficiencies. But to me, zinc is the variable. Okay? And how we detect that, it's very simple. So the taste test is fun, but there are two things that I like that I learned many, many years ago, but it's been so helpful, particularly for parents and colleagues, is when you have an adolescent, any family docs, if you have an adolescent who's growing, what is their alk phos? High, right? So what do we see? Hundreds and hundreds, and we don't say anything because we say, oh good, they're growing. And then look at your eating disorder, your anorexic patients. Not only are they not high, they're low. And alk phos is a zinc-dependent enzyme. So low alk phos helps us zinc. And the white blood cell count, I saw a kid, actually it was a young adult with a white blood cell of 1.7 today, and the primary care doctor said, oh, she always runs low. Again, another one of our kind of functional markers of zinc deficiency. And then we can do the taste test, but I have no issues with a vegetarian diet, but I just urge you to ask the question, an adolescent vegetarian diet is likely zinc deficient. We likely have this family history, genetic, premorbid temperament. So if we understand all that, we can start thinking of things like prevention, whether it's a multivitamin or zinc, or just a nutritional counseling for the parents. Major areas of prevention. And then treatment. I got a lovely note from a guy in Africa with his family, had twins, who started developing severe symptoms of anorexia and OCD, and he read the book and started on zinc and a couple supplements and was able to turn it around. So eating anorexia nervosa in particular early, the beginning of this malnutrition stage, we can reverse this life-threatening illness.
Do you think any orthorexic tendencies could be that, not just vegetarianism, gluten-free, dairy-free, unprotected low-allergy diet?
Yeah, absolutely. So the orthorexia, have you heard that term now? The people obsessed with healthy food, maybe everyone in this room is. And that's okay. So I don't like the term orthorexia. The ones that have taken it to extreme that end up in our hospital, it's really OCD. I mean, they have a serious mental illness, not based on health. And that's the OCD. But yes, similar mechanism.
And is zinc treatment effective later on when it's been years and years of OCD and anorexia?
Well, with anything, years and years makes things very difficult, but absolutely it's part of the treatment. I have cases, that, had struggled for many, many years and was able to start supplements and completely recovered. So it's not as simple as our 12 to 16-year-olds, but it certainly can be done. And it's once they get older, it's usually not zinc deficiency. It's combined with many, many multiple gut issues and malnutrition issues.
What's the presumed pathophysiology
Of
zinc deficiency causing or worsening the OCD-like behavior and getting to the point of suicidality with anorexia? That's kind of, I can't understand that.
Well, I should say something like you got to read the book, so it's a complicated answer, but it's a good question. Zinc is, let me just give you the list, the random list, then I'll summarize it, okay? Zinc is critical for hydrochloric acid, okay? Carbonic anhydrase, so you need zinc to start digesting any food. You need zinc for all of our other pancreatic enzymes. You need zinc to make melatonin. You need zinc in the NMDA receptors. You need zinc to help, well, all our immune systems. But and then there are a few other.
It's not one, it's multiple. All of the 300 mechanisms of action of zinc, I picked a number of 300.
Pretty close, yes. I think there's the areas of zinc in the brain, in certain parts of the brain that we're not really that articulate about, that probably needs to be done more research, but there's just so many areas that zinc affects both brain function and digestion that it's a cascade. The direct kind of keeping the anorexia going is the taste and appetite. So all of our taste receptors, gustin, these are zinc-dependent enzymes. So without adequate zinc, we don't taste our food. This is a tremendous problem in depression in the elderly. Someone was talking about getting our elderly patients to eat. Well, when they're zinc deficient, the food doesn't taste good. So they brought food or someone cooked some food, it doesn't taste good, they're just not that motivated to eat. So the lack of taste, our anorexic patients, they start mixing Tabasco and mustard and doing lots of interesting things to try to taste. But it's that decreased sensation of taste, that decreased appetite, that starts that chronic cycle of malnutrition. So we can keep going on zinc. I want to talk about lithium. How many people use low-dose lithium? Okay. I mean, to me, it's going to be to me it's the miracle drug. And it's not a drug, it's an essential nutrient. And the research is quite profound in the psychiatric literature. We know that lithium as a medication has profound effects on suicide prevention. It's the only, that and Clozaril, it's the only medicine that's been shown to decrease suicide. And it decreases suicide in bipolar patients 7 to 20 times, depending on the study. Okay? So profound effects on decreased suicidality at dosages, 1,200 to 1,500 milligrams. Okay, but what happens? I would never prescribe lithium at those dosages now because what happens? You get thyroid is the most common, thyroid problems and kidney problems. I have a number of patients who I've seen who have done incredibly well. Again, those strong family histories of bipolar disorder, and they get kidney damage, they're taken off lithium, and they're stuck in bed, depressed for years before we saw them. Let me tell you about the story of this one patient on lithium for 20 plus years, very, very strong family history of suicides and bipolar, kidney damage, had to stop. I saw her after 2 years of sitting in bed. We put her on low dose lithium, 5 to 10 milligrams, and there were a few other things, not many though, B12 and a couple other deficiencies, and she did fine. And then she went to her nephrologist, who said, you cannot take lithium anymore. And I tried to write him a note and said the dose, she had a blood level of 0.1, but she's a very nice woman, tried to please him, so she said that she stopped it, and then she crashed again. So what she did, without telling me or her, she was able to find the dose of lithium orotate that prevented her depression. And she got it down to 5 milligrams every 4 days. If she took that, she was euthymic. She didn't tell him, and she didn't tell me for a while, but she eventually told me because she wanted to be a good patient. Monitored blood levels, her kidney function, I've seen her for over 5 years, has never changed.
When you say 5 to 10, are you talking about orotate or carbonate?
Orotate. That I use. So let's keep going because I think it's just so incredibly helpful.
Can you say what's that equivalent to in lithium carbonate?
We can't. Let me get to that though. The other studies that I think are important, I don't know how many people are familiar with, is the lithium tested in drinking water. Are you familiar with those studies? So in the 80s, we did 5 communities in Texas, okay? And it was pretty dramatic. The lower levels of lithium in the drinking water, because lithium is in the soil, the higher rates of suicide, homicide, and depression. Okay? So pretty good study. And then we repeated it in Japan. And I think it was 12 different communities in Japan. Same thing. Lower levels of lithium, high rates of suicide. It was repeated in Austria and in England. England wasn't as dramatic, and there's some reason, but still there. So pretty significant results. The lower levels of lithium in the water affecting depression and suicide was the most consistent variable. Okay? So we have pretty good research to demonstrate that lithium has this anti-suicide effect at very low dosages. The work that I just want to share with you, I read, and it was probably in medical school, from Jonathan Wright. Used to read his prevention magazine clinics. He had, I forget what he called them, but he used to write cases. So he described that he would use lithium orotate with family histories of substance abuse. Okay? So I've always used it over the years with family histories of bipolar. Okay, so remember that genetic history we took? We asked the question, and the patient in front of you has no signs of bipolar, but they might be depressed. Okay? I use lithium orotate all the time in those families, or they're beginning to get hypomanic, they don't want medicines, lithium orotate. But after reading that Jonathan Wright thing, I've started looking at lithium in those individuals with family histories of substance abuse. And the one symptom that they present with in your office is irritability. And I really, not that you can read my writing, but it really is, if you just think of low-dose lithium and irritability, over the next couple years, you're going to see some dramatic cases. Because irritability is a word that doesn't make a lot of sense, or it's hard to define, but you begin to get it. Your receptionists are probably going to get it first. They're going to know the patients that are difficult. And road rage is one of the most consistent things that we've cured with low-dose lithium. But the underlying theme is that irritability. Like, I don't mean to yell at my husband, and I feel bad, but I'm so nasty. I had a woman, she was actually a therapist, who, on low-dose lithium, had such a dramatic response. She was just crying in my office because she realized how bad she treated her kids and her husband. Because she was always angry. But, I mean, there wasn't a diagnosis. but she was just irritable and angry. And this lithium, this 5 milligrams, just took that away. And she did have a family history. And so irritability is broad, but if we start throwing, different concepts, road rage, arguing in the supermarket, arguing in the restaurant, you begin to get a flavor of someone who might benefit. Again, with my world of testing, I've been using hair analysis, trace mineral hair analysis, to look at lithium levels. And I treat, oftentimes we get non-detectable lithium in the hair, and I'm using lithium for that. And this concept of irritability, I'll kind of end with the ADHD child. So there's a subset of ADHD kids. They're usually angry, impulsive, bordering on aggressive, that dramatically responds to this low-dose lithium. So what we don't want is our practitioners to prescribe low-dose lithium to every ADHD kid. Okay? Because not every ADHD kid has a problem. But I've treated hundreds over the years. Some of it's based on family history. So I have a 9-year-old sitting in the office. Usually these kids I'm seeing earlier because they're kicked out of preschool. Right? They're 5 and they're 6. They're kicked out of preschool. And we got a family history of bipolar. Look at a hair analysis, no detectable lithium. And we start with, actually for the kids, we're starting off with micrograms, 500 micrograms to 1 milligram. And we get dramatic improvement. It's not always the answer. So again, some of these kids over the years still might need a stimulant for attention and focus. But this aggressive, this irritability, and we prevent what I had in my office yesterday, which is a parent who was a therapist in the mental health field who had his 4-year-old on Abilify. Okay? Now this is a gentleman who, one of these kids who got kicked out of preschool, very, very aggressive, very, very hyperactive. I saw him when he was put on Abilify seeing another psychiatrist, and I told him that we're going to do these tests. And he had a couple dramatic things. He had profound gut problems with elevations of HPA, which is a Clostridium metabolite, and he had this non-detectable lithium. He had improvement in probiotics, a couple weeks or a month, and then we added these lithium, and then really dramatic. And it was, I wrote all the quotes down of what the parents said, how dramatic it was. And then he told me, oh, but he's still taking the Abilify. Because last time I saw him, I said, I can't treat you if you're taking Abilify from another psychiatrist. Because, why? If this kid has a problem, okay, 4-year-old taking Abilify, it's not approved for kids at all. If he had a problem, guess who in the lawsuit is going to be at fault? The guy who prescribed Abilify to a 4-year-old child, or me that gave him a couple drops of lithium or a vitamin B? And so I had to, and this guy was a referral of someone who I really respect. I told him this 2 months ago, and I had to tell him again, because he kept asking, should he repeat the test? I said, I can't really treat you anymore. Okay? And I actually told him that I would continue your son on Abilify. Okay, when I saw him, he was on 2 milligrams. Okay? And I said, we need to go to 1 milligram. And my job was to taper him off Abilify. And he comes in, and the psychiatrist put him up to 4 milligrams, and he got rageful and irritable, so they cut him down to 3. So he was back in the office at 3. I said, I'm not going to take your son off, but I need to be in control of that medicine because I don't believe it's safe. Our brains develop until we're 22, and I don't know what Abilify does to your 4-year-old son's brain. Now, if we take him off it and he really crashes, then it's a decision that you can make with knowing the risks and benefits. But I don't think your son needs Abilify. So it's probably the first patient I've fired in many, many years. The point is, lithium can be a tremendous role in prevention. And that's why I wanted to talk about these two things. Prevention of mood disorders. We know our parents have this illness. If we start developing symptoms, we might be able to treat it before someone becomes manic or severely depressed with low-dose lithium. you asked about, I use Orotate, but Nasser Ghami, who's the head of mood disorder research at Tufts, New England Medical Center, has written a lot of books. He's very much into low-dose lithium, and he just uses lithium citrate, liquid lithium citrate, and uses a couple milligrams. Because the research is there, it's not going to be continued very much because there's no money in it, but looking at lithium as a prevention for Alzheimer's and dementia. Because if you put lithium in the test tube with 2 neurons, you can watch those neurons grow and expand. So someone used the term, it's like miracle grow for neurons. Okay, so there's a nice literature out there, but it's also probably not going to be continued very long because there's not much profit in low-dose lithium for the treatment of dementia or Alzheimer's. But my reading of the literature, I think everyone should take it, and we're kind of I'm trying to figure out what the dose is for prevention, and I think it's lower than 5. I think it's less than 2 milligrams for prevention of cognitive decline.
What foods are high in lithium?
Good question. I've been trying to figure that out, and I don't well, it's not meat and animal products, so it's more grains and vegetarians. But I heard, and I confirmed that thyme, okay, the herb thyme, is one of the highest edible sources of lithium. And I was giving a talk for the Native American Suicide Prevention Conference, and talking about lithium and suicide prevention. And there was a gentleman from a Middle East country, and I'm not sure he was, who told me that 3 meals a day at their table, they would have olive oil with thyme. And he did say, and I'm not sure what his research is, he said, and there's very little suicide in my country. And he was wondering if that had to do with it. But so the long answer is thyme is the most concentrated source I know of.
What are the forms of zinc that you use, and what are the ranges?
It's again, a lot of my practice is treating too much zinc. You know, practitioners or patients reading zinc is good for you. So I'm going to take 100, 200 milligrams. So for our anorexia treatment, it's not high dosages. The research is 50 milligrams. I use between 30 and 90. 60 is the average. So we're not talking about mega dosages. It's pretty modest dosages. I haven't found any difference between any of the forms of zinc. So, and the research, the studies, they've all used different ones. There's a fascinating story about when you become zinc deficient. It's one of the few times that biology hasn't made sense to me. But when we become zinc deficient, we actually absorb less zinc. So something happened. So I like, for my really severe patients, for liquid zinc. It doesn't always happen, and we have success with tablets, but there is less absorption of zinc in zinc deficient patients.
You talk about giving lithium to depression if they have family history. Do you ever give lithium as a trial for just depression without any family history?
Oh, absolutely, yes.
How long do you try for it? What's the trial period?
If there's irritability, it's pretty fast acting, and it's one of those dramatic parts of my practice when it works. If someone is just kind of fatigued and sad and lethargic, lithium is not a good mood elevator. If someone has that edgy, anxious, irritable, it's usually 2 to 4 weeks. I wouldn't give it longer for the treatment of depression. Even for high dosages, lithium doesn't get you out of a depression. It kind of prevents the fall and helps you in a mania. And we've treated bipolar patients that we give high dose of lithium, they're manic and they crash. So it's not great for just what we call unipolar depression. If they have that edge, it can be very helpful.
Isn't that, are you talking about the kind of symptom, what you might call reactivity, that people take SSRIs? Is that the same kind of thing you're talking about?
Similar, absolutely, yeah.
So for that kind of patient who's reactive, snapping at people, or internally snapping at themselves, would you choose that over, say, an SSRI?
For some, I might do both. You know, we're talking about And I use this analogy a lot in my binge eating kind of talks. Severe binge eating, again, I think is very undertreated. And sometimes we need to use multiple medications, just like our medical colleagues do for blood pressure, AIDS, or any of our other illnesses. So sometimes different mechanisms, and whether it's nutrients or meds. So low-dose lithium and Lamictal is common in my practice. Low-dose lithium and an SSRI maybe. So sometimes combinations of supplements with medications can be very helpful.
Now, is there a particular blood test for this that's checking for you talked about lithium deficiency. Is there
your blood tests are going to be none. So if we look for a lithium level. So the only test that I've been doing, and I've used the same lab for 23 years, is a hair test. So trace mineral hair analysis for lithium levels. And again, it's been pretty accurate. Most of us in this room will have detectable lithium levels, and a few people, they have non-detectable lithium. And those are the patients that I more aggressively treat, particularly with a family history, or particularly if I get 1 + 1 = 2, family history and symptoms and no detectable lithium.
That's the lab.
What?
What lab do you use?
I did guide the Texas Trace Elements, TEI, Trace Elements International, just because I've used them for 23 years. You know, Doctors Data has a hair analysis. Do you guys have a hair analysis? Okay.
How often are you following the hair testing?
That's a good question. I follow it pretty closely for elevated copper. I don't follow it for the low lithium because it's going to be fine in 3 months. It doesn't give me much information. But sometimes I do 3 people in the same family, particularly if they're well water, and sometimes they're all low in lithium, or sometimes every member in the family is completely normal except for the patient in front of us.
So if someone shows up with a hair analysis and they're not specifically complaining of depression, but it is undetectable, would you preemptively treat with low-dose lithium, assuming that they probably have some other imbalance?
If they had symptoms of that irritability with depression, yes.
But it's not what they presented for, but sort of in the workup, you uncover that they're not fully docked. So you
Right. Yes, low dose. And I think, again, the orotate, the 5 milligrams, I think I'm starting to use lower doses for prevention. So I have patients, a number of patients over the years, bipolar patients who are on the high dosages that are taking 10 milligrams a day, but when they notice kind of feeling the hypomanic and their mood starting to elevate, they might go up to 20 and then cut back to the 10. Except for those with kidney damage, I rarely ever get a blood level. So we're talking about 10 milligrams of lithium orotate. The blood is non-detectable.
I treated a 6-year-old girl who had oppositional kind and a lot of cancers, and her glutamate was high, and I gave her 5 milligrams of lithium orotate, and she got worse. Any thoughts about what's going on?
I've seen 2 cases of individuals getting worse on lithium. One individual got kind of sedated is not quite the word, but their thoughts were so slowed that it really kind of was scary. And I only have 1 case of somebody who got agitated on lithium orotate, and probably thousands. So it's not common, but I have seen it, and I'm not sure what the mechanism would be. And how old was it again? 6. Okay, so for 6-year-old, I would never use 5 milligrams. Okay, so for 6-year-old, I'm using 500 micrograms of liquid lithium, and I've never gone beyond 1 milligram. So that could be part of it. Yeah.
So will you treat without the blood test? Without the hair test, I'm sorry.
Will I treat with low-dose lithium? If I have my family history and my symptom picture, yes. Good. Yes, because I think it's pretty benign and safe.
So for treating persistent depression, the alien pinch of this might be reasonably safe to
Yes. Yeah. Again, it doesn't elevate the mood. So if it's a really profound, deep, dark depression, lithium is not the answer.
So what's the normal level for zinc?
The normal what?
Level for zinc.
Well, I don't know if we have a normal. I think if you get a serum test, the range, every lab is slightly different. Could be anywhere from 70 to 140. I kind of have this magic number. I like it over 100, but I don't think serum zinc is very accurate. So we look at the taste test. We look at our functional markers. Where's our alk-phos and white blood cell count? We look at our RBC zinc. So zinc is an interesting thing, and I look at here, the zinc-copper ratio is helpful. So for zinc, there's not one test. I'm putting together 6 tests to kind of get a sense of how aggressive to treat.
What's the taste test?
The taste test is a very dilute zinc sulfate liquid that you just take a couple teaspoons in your mouth and you swish it around, and it's kind of graded in 4. And if you have adequate zinc, you should have this strong, bitter taste. You go, ugh, it's a metallic taste, and you want to spit it out. And then and then it's graded from no taste. Oh, it tastes like water. And then in between, a little taste and much taste. So there's kind of 4 things. And it's pretty dramatic. It's a good party game. You pass it around, and and it's been pretty accurate. I mean, what it hasn't been accurate is always reflecting whether someone is healthy or not. It doesn't mean this person is quite ill, but I think as we followed up over the years, because we did it for years in the hospital for all the staff and all the patients, so we did it a lot, that, in follow-up, most people had other markers of zinc deficiency as well.
What's your opinion on if someone is deficient, is this a lifelong supplementation versus get them to steady state and then discontinue?
I think most of my world is sorting out the getting people off, because we start off, we use too many supplements because we see all these abnormalities and we're trying to help patients. They can't sustain it most of the time. So oftentimes, again, if we deal with the gut and digestion, there are not many supplements that I think are lifelong. B12, might be, depending on genetics. But oftentimes, particularly for the eating disorder patients, once they start eating and restore zinc, it's not lifelong. The lithium orotate might be, low dose.
What about the zinc studies where the mother was deficient, so the offspring were deficient, and they couldn't really bring them back up to normal, even supplementing them for years? And there's something funny about there.
There's pretty, I don't know that particular study, but that makes sense. And, I believe we talk about substance abuse, but certainly our eating disorder, that chronic relapse in course is what happens when they leave the hospital. They tend to relapse, and oftentimes is because of the underlying zinc deficiency is not treated. Well, I thank you for your time on a rainy night, and appreciate your help.
That was awesome. Thank you. I have the pleasure of having, first off, I'm Wendy Trudeau. I'm I'm actually the chief operating officer here, and I'm also a practicing gynecologist. So first off, thank you all so much for coming tonight. In the last month, I am really honored to have heard what I would consider to be the godfathers of functional medicine, and you have just essentially put the icing on the cake. So thank you for coming here tonight, because it's truly an honor to have heard you speak. Ed's been talking about you for years, and Waltham has just seemed really far away until tonight. So to complete our evening, we have some sweets, we have some networking, and an ability to just meet each other and mingle. I think what's really amazing is just this community of people who have come together tonight. So feel free to stick around and talk to each other, and thank you for coming.